you all for joining. Thank you all for joining us. This is our OR surgical tech session. We have John Uperti. He is a first surgical assistant in the operating room at Mary Washington Healthcare. Go ahead and take it away, John.
Hey, good afternoon, everybody. As Jolene said, my name is John Uperti. I'm a surgical certified first assistant and surgical technologist with Mary Washington Healthcare. So what that really means, you hear a lot of different wording about scrub techs, surgical techs, and in healthcare, you have a lot of nursing-based positions and you have a lot of tech-based positions where we help in different facets as allied health professionals in any facet of healthcare you can see. So if you look at what you see on a normal basis watching TV, most everybody's watched Grey's Anatomy. I know I've watched my fair share of Grey's Anatomy, but in the pictures you see on the left side of your screen, you see everything based on the physicians, these elaborate representations of these triumphs and, the big downfalls, the sadness, the great achievements, but you see it on their side when they're walking in the OR, the operation and walking out. And it's very zoomed in, specifying on what you see. Now, if we were to zoom out a little bit and you start seeing all those other people around in those pictures, you see that one person in the back in Grey's Anatomy in particular. Her name is Boki. We all hear it in the names, but her real name is Ray. And she's a surgical technologist and she was an RN in the OR for about 23 years. And she went on to Grey's Anatomy to be essentially their medical officer. She checked, made sure everything was realistic. So all the surgeries are checked by her. She was a real scrub tech in real life. And now she's on a TV show representing the exact thing she did for so many years. Now, surgical techs are a very wild position. We're seen in a lot of different ways as the surgeon's right hand. The instrumentation specialists, we know every instrument a surgeon may need, they could possibly need, and they won't need, right? We prepare the operating room from start to finish. If there's a surgery at 8 o'clock, we start everything off early in the morning at 6 o'clock, opening up different drapes and tables, scrubbing into surgery, getting all sterile, and then setting everything up how the doctors want for their cases. Some cases are 30 minutes long, and in my profession, I personally am a cardiac surgical technologist, so our cases are 13 hours sometimes, but hopefully on a good day, as short as 5 to 6 hours. Now, if we look at surgical techs in scrubbing, you hear that term scrub a lot. I'm going to go scrub in, on these TV shows. Well, that's also another nickname for my position called a scrub tech. Scrubbing can be using, a specialized scrub brush to scrub your hands to make yourself surgically clean, to get into surgery and don on your sterile gowns. But we use that name kind of in a fun way as a scrub tech. We're a technologist, we're a technician. You still work in the operating room and you scrub in. So it kind of just fits the wording all together, one in one. Now, the best way I've ever heard someone talk about a surgical tech is considering us as a professional golf caddy, right? If any of you have ever miserably watched golf on TV or played golf in person, you see that a caddy is a very intricate point to a golfer. A caddy is somebody who is almost at that professional level, hasn't made that big break yet. They know golf as well, if not better, than the golfers themselves. They know every green. They go out the day before and they look at how the green's angled. They know how the balls are going to roll. They know how the grass is, if it's wet, if it's dry, and how the course is going to react. That's exactly what we do in surgery. Okay, we check everything ahead of time. We know the patient's anatomy. We know what we can get into, what we need to get out of, and then all the right clubs or all the right instruments to use. When you're looking at this certain portion of surgery and you see something's bleeding, or if you're on a golf course and see a shot coming out of a bunker, you need to get a different club or a different instrument. We try to anticipate the best we can to make our surgeon's job a lot easier, right? The goal is silent surgery. What I mean by that is throughout surgery, there's always going to be conversations, questioning the anatomy, where we're going to go next, how we're going to approach the next step of surgery. But one thing we never want to do is have to ask for something or be asked for something. Our goal is to have a silent case on our part. We want to know every step ahead of time and hand them the next instrument, right? So education for a surgical technologist, you have to go through a national board certified program in the area where we have Germana, who's going to be starting their surgical tech program in fall, ECPI University, as well as Lord Fairfax. I think those are the three in the area that we mostly work with. It takes about 2 years to get through school, 18 months to 2 years, depending if you get an associate's degree along with your certification. And then the other route is military trained scrubs. At least half of the scrubs I work with were military scrubs at one point and starting off their career that way. Now, going through those two different facets of education, through your certification and your certified program, you'll have to sit for the national board exam through the National Board of Surgical Technologists and Surgical Assistants to be able to certify that you have the base knowledge, a long 200 question test to get through it and say you're good. With military trained personnel, if you have, I believe it's 5 to 7 years of military training, you don't need to sit for a certification. You're considered a hands-on trained military technologist. So those two things kind of work in coincidence with each other. We do the same thing in the operating room. We're essentially the same thing. Now, if we go talk about my career a little bit, I was a student at ECPI University out of Manassas, Virginia. My mom actually got me into the thought of a healthcare career. She's an operating room nurse at Alexandria Hospital. She's been a nurse in the operating room for 33 years. She started off her career in cardiac surgery, which is kind of became my heart and soul knowing that and kind of following my mom's footsteps. But I did my entire clinical studentship at Mary Washington Hospital in the operating room. It's close to where I live from Woodbridge, but also Mary Washington has a big presence. You know, the last community hospital that does the large surgeries and the traumas that we do here, it's something you don't see from a smaller corporation, but they do it so well. And it really drew me in, being able to be at a trauma facility that does open trauma surgeries, trauma level 2, heart surgery, thoracic surgery. It's incredible to be a part of. So once I graduated from ECPI University, I took a job with Mary Washington Healthcare with the hopes of one day working in the cardiac surgery department. I started out doing a lot of general surgery and orthopedic surgery, especially. And after a little bit of time, I made my transition into cardiac surgery and thoracic surgery with a side specialty in vascular surgery. I fell in love with it, dove deep, took a lot of call. And that's a big part of what these jobs are, taking that emergency call. If somebody does get hurt in the middle of the night and you need to do an emergency surgery, we are that go-to person to come in with the physician, right? So after I started in my cardiac surgery, I worked with the team very tightly. Ended up growing to be the first technologist or tech in the cardiac surgery leadership at Mary Washington Hospital ever, which is a big feat for me. And I really was a push for me. And I loved every bit of it. With doing that, we explore new hybrid procedures, and we're always expanding our surgical knowledge every day. And the field is expanding so quickly. And that's kind of the base of my presentation, is our point and our position in the advancements of surgery. There's always a team behind the scenes getting everything ready for that big photo when the big surgery is completed and this happened, it goes in the news. There's a lot that goes behind that, and we're a part of that. Our big hybrid procedures here at Mary Washington Hospital, where we transition cardiac cath lab, which is where people put stents in the heart through femoral access in your legs, and they feed up small wires in these stents to help heart disease. Now, we coincide hybridly with the open heart surgery and our cath lab to put new valves in patients' hearts through your legs. So there's no longer the ability to open the chest. It's not needed in a lot of cases. They feed up a small wire through your groin, all the way up through the blood vessels into your heart, and they expand the new valve with a balloon, which is an amazing, crazy concept, but it's something that's reality now. And it's very cool to be a part of that with Mary Washington Hospital. Now, getting back to my journey with Mary Washington, after becoming in my surgical leadership, I also went on a surgical mission trip to Honduras, and I operated for 7 days in Honduras at a small community hospital doing gynecologic and general surgeries for people of the area that couldn't get shipped out to bigger centers to have these surgeries done. It was an amazing opportunity to see what life is like in other countries in healthcare, and to see really how big this step is that especially trauma centers are seeing in the US compared to what's happening in other countries. After a lot of my time in the OR as a surgical technologist, being that scrub tech and handing instruments and being that golf caddy, I aspired into what's called the CSFA title, which is the Certified Surgical First Assistant title. Which is the person, you're essentially the surgeon's other set of hands. You help operate, you assist in retraction, you close patients, you help open patients. It's just a bit of a step up from the job I'm already in. And it was a big, just a big step and kind of a hardship to go through school again while working full-time in cardiac surgery. So some pictures I wanted to put in my profile, starting out as a student all the way on the left side, and then getting my first picture of my first day at Mary Washington Hospital, and then doing my orientations through orthopedic surgery and my gigantic spacesuit you see me in with my saws. And then a good friend of mine that I tutored in school that also got hired here at Mary Washington Hospital. He's now a lead for orthopedic surgery. And then these are the pictures from my Honduran mission trip in operations. So very weird experience, as you can see in the top right picture. That's an operating room. It looks a lot different from what you see behind me, right? A lot of pumps, electronics, very fancy equipment here. There they have the same bed they've been using since the 80s that was donated to them. Their anesthesia boxes, which you're on right now, are electronic medication systems. Theirs was a toolbox. So kind of having that humbling moment to see the difference in surgery was pretty amazing. I took this trip with my mom in the picture in the middle and my sister on the side. Like I mentioned before, my mom is an OR nurse and my sister is an ICU nurse. So being able to kind of, as a family, initiate in this giving back moment in healthcare and advancing myself. Now, these are a lot of pictures of my current team now, and this is a big part for me because we've grown with a very young team in cardiac surgery and had a lot of cool experiences with Mary Washington to make it an amazing career. On our top left here is myself and our new surgical tech in the cardiac operating room. His name is Kenji. We had the opportunity to do cadaver labs together with the company, and we got to do our own heart transplants on cadavers. So that's me holding a human heart in the top left. And just beside that is me and one of my preceptors when I was learning how to be a surgical assistant and harvesting my first vein. For heart surgery, of course, we take and we harvest vein conduits out of our legs and arms to be used in the heart as bypasses for portions of the heart that need blood supply. So that was my first vein harvest, a very cool moment. And the picture just to the right of that was me starting the first harvesting of that vein in a different sequence. And the photo just to the right of that is a long string of people. Mary Washington Hospital was the first cardiac center to do a transfemoral aortic valve, which is that process I talked about earlier, feeding a wire from your groin all the way to the heart to give you a new valve on a balloon. We did it along with a new system called a shockwave, which is where we actually digitally pulsed calcium out of the way so we can get that valve through all the way up from the groin to the heart. And we were the first program in the country to be able to do that. So it's a picture recognizing that situation. And then just some funny pictures on the right side of letting things go a little too far and your water turns all the way into ice when you let it get a little too cold in surgery. And then just some photos of my team finding some old instruments that you used to have to use a hammer and a long blade to make some things work in surgery. And then my team training on a new transition system. So overall, surgery for me has become the most important thing in my life. I would never go back to change anything. I started my adult life as a mechanic working on cars, working in dealerships, and I made a quick transition due to my mom to healthcare, and I wouldn't give anything up. It's been an amazing opportunity, especially with Mary Washington Hospital, to be able to have such a vast opportunity in different surgical stations. We have the options to do urology, gynecology, general surgery, thoracic surgery, vascular surgery, different facets of orthopedic surgery, as well as cardiac surgery. So very cool opportunity as a student, and especially as an employee. And there's always this amazing room for growth. And that was something big for me when I started out, because there's always this talk of a glass ceiling when you're looking into new jobs and you're going to school for things. The glass ceiling in healthcare is essentially non-existent. There's always something new to learn. Now, you just have to realize that the glass ceiling is completely dependent on your output. You have to work to receive new knowledge. You have to put yourself out there to receive something new from a physician, right? To get trusted to move to the next level, you have to put in the hard work. And that's what healthcare is all about, putting in the work to get the output from the patients, right? We do our job and we work really hard to make sure we have fantastic outcomes, and in due time, that will pay you back with the experience you need to move on to something else. So being able to go from a surgical tech to a surgical assistant has been an amazing opportunity. And that I try to tell most techs, when you feel ready and if you feel excited by surgery as much as I did, the surgical first assistant option is, hands down the best thing I've ever done. It's really hard and it takes up most of your time, especially the clinical hours, being in the hospital, logging hours. It's tough, but well worth it. So, it's an amazing career path, and I hope that I've helped anybody who has been a little questioning about it, that this is amazing. And, would hope to see anybody who wants to come through Mary Washington for the opportunity as a student. I hope to see you.
Let's see if we have any questions from our let's see. Oh, Stacy has one. Okay. I'm going to go ahead and just read it. Have you
Sure.
ever considered going on to be a surgeon?
So I was actually just saying it yesterday to a couple colleagues of mine. The only thing I would ever take back and go back and redo, if I could take school more seriously as a high school student, and realize that there are more priorities than going to hang out with my friends, I would love to go back and get the grades I need to go to med school. I have always thought about it, and it's, especially not being in healthcare, if I could go back and do anything, I would have gone to med school to become a surgeon. Especially now with the opportunity to get closer with a lot of the doctors I work with, get more on a personal basis with them. It's something that, yeah, I would have absolutely loved to do. They're so skilled, and what they bring to the table is incredible. The knowledge that surgeons bring forth, I mean, just to be able to look at something and tell you how it works, every bit of what comes into it and out of it off the top of their head, it blows my mind. So I started to do my hardest to try to get to that education level, but it's nothing trumps that. People, they save lives off of their knowledge in their hands, and it's an amazing thing to be a part of. And but yes, in a short answer, yes, I would have loved to.
But what's next for you, John? I mean, because you make it sound like these things, you could still move it forward. I mean, what is next for you in terms of, I've had the good fortune of hearing a little bit about your career, the last time we've done an event. What is next, in terms of your career pathway?
So mine is exploring all of the surgery facets that I've explored before, general surgery, orthopedic surgery, thoracic and vascular, everything that I've done as a surgical technologist. And I feel like I've gotten to a pretty high understanding level of becoming leadership. But now I'm going back to essentially first base. I'm going to start it all over again as a surgical assistant to essentially re-understand everything. There's a different viewpoint being next to and being across from. When you're next to a surgeon and you're passing those instruments and you're understanding, and I know what's going on, I understand the anatomy, being the one who actually has to do it with your hands, it's an entirely new ball game. So understanding anticipation isn't grabbing something to give, it's being the person who does it is something that I'm still learning every day. So yeah, again, learning is the biggest portion of the experience in the operating room. The glass ceiling, people can refer to that glass ceiling as the financial thing, but I refer to the glass ceiling as a learning opportunity. You never know it's impossible to know everything in surgery. So there's always an opportunity to learn. And that's how I'm seeing my future as a surgical assistant. I'm just taking my learning to another level.
I'm looking at the chat. I don't see another question right now, but my team is on here. And, if you guys see another question, let me, oh, wait a minute. I was going to ask a question, but Kayla has a question for you, John. She says, or she's asking, what has been the most interesting procedure that you probably have done in your career thus far?
Interesting is a hard one, because there's a lot of things that can go wrong in ways that you don't want surgery to be involved in, but you have to be. But I'll take that more on a side of what's excited me the most. Being a part of cardiac surgery, there are some big cases that come in, trauma cases, gunshots, things like that. And I never thought I'd want to wake up in the middle of the night to a phone call saying you have to go to work now. But if I don't look forward to that phone call, I love it. Being called in the middle of the night for emergency heart surgery is a wild thing. And I think it's honestly my favorite part of what I do. Somebody who's in the absolute brink of death and being able to be a part of the team that can bring them back. So I would say the most interesting surgeries I've been a part of would either be an abdominal compartment syndrome with an adult patient when I was actually just out of studenthood. It was the first case I did by myself. I was coming off orientation that day at the end of the day. So then the following, I think it was a Wednesday, the next day I would be a full surgical technologist, be able to operate on my own. And that afternoon, an emergency trauma came in and everybody was busy. I said, John, can you do it? I said, sure. And this gentleman had ascites, which is a fluid buildup in your abdomen. And it built up so much pressure that it was causing blood flow constrictions in their abdomen. And so we have to take him to the operating room now. And I'll never forget, they took the knife and they made the incision super fast. Everyone's yelling and screaming. And a volcano erupted of all this fluid and blood. And it came about 2 feet. And it was incredible. I'll never forget that. But it was something where he came in on the brink of death. And within 2 hours, he was stable, transferred to the ICU, and everything was okay. So,
Wow. Oh,
but nothing beats removing ping pong balls from parts of the body as well in surgery that there shouldn't be. But that, that would be the interesting ones. But
oh, we have a lot of things coming in the chat. I think that triggered something right there, John. Okay, hold on.
sure.
My colleagues, okay, come on, colleagues, help me out here because these are coming in a little fast.
So the next one is, where did you take your surgical assistant? And on top of that, the next one kind of coincides. What are the requirements to get in the surgical assistant program?
So I did my surgical assistant program with Meridian Institute of Surgical Assisting. It's in Nashville, Tennessee. So one of the big national board I spoke about before was the National Board of Surgical Technology and Surgical First Assistants. That governing program has essentially two sublets to it. You have the Association of Surgical Technologists, which is kind of like, our AORN, so it's the Association of Surgical Technologists. We kind of answer to them. All of our accreditation stuff goes through them in a way. But for assistants, it's the Association of Surgical Assistants. Again, another simple phrase, but their recommended programs, they have a list of who they accredit. And one of the biggest, most used programs is Meridian Institute. Most of the assistants that I've gone to meet that weren't physicians from other countries, which is another amazing way of surgical assistants happening, they take an exam showing that they were a physician in another country. They can be an assistant here in the US. But coming from a surgical tech, you need to go to a special program that allows you to go as a tech to an assistant. So you can kind of be taught on a level where you can understand your knowledge in surgery and be able to adapt that into surgical assisting. And I think Meridian Institute did an amazing job with that. That program, to speak on it a little more to add, just in case any more questions come in about it, it's one additional year on top of your other trainings. So it's 1 year, including 150 surgical hour cases. So they have to be an allowed surgical case that you have to function as a first primary assistant with a surgeon. Now, Meridian Surgical Assistants requires you to have been a surgical technologist and be certified as a surgical technologist through the MBS TSA, like I mentioned before. All the other restrictions have essentially been lifted. It used to be 3-year minimum requirement of being a tech first before you can apply to be an assistant. But now you essentially could graduate and the next day apply for, graduate and certify, and then the next day apply for surgical assisting. Now, from my experience, I really wouldn't recommend that. You need to be a little wet behind the ears, if that makes sense. You can't be fresh. You can't be brand new. You need to know some surgery before you go into that. When I went to my program, most people who were there had been in surgery for 7 to 15 years before they joined that program. And myself only been doing it for 2.5, 3 years at that point. I was looked at as kind of the newbie in the group, but of course, hands-on and knowledge that, everyone became an equal. But having some knowledge and background in the surgical field is huge to these surgeries because they expect you to know everything the day you get there. You're taking an anatomy test and you're directly in the lab being hands-on with live pigs. Well, your goal is to keep your pig alive the entire day as you operate on them and take out different organs. And you have to keep them alive. So that's Meridian Institute, and it's an amazing program. You can look into them. They are not crazy expensive to do out of pocket, but most facilities like Mary Washington will back you and help pay for that project once you get it through. And if you were hired on as a tech, they do help pay for those projects.
We have one student now that's in the CST program at ECPI, and I think you kind of answered their questions. Someone said I had OR observation and I'm thinking about specializing in the field. They thanked you for all you do. Someone said, since you have done so many procedures, are you more at ease to have one done by your own colleagues or even a student that you have taught?
Ooh. Ooh. That's actually
no, John.
That's an amazing question. So I love to hear you're from ECPI. Of course, my alma mater. It's an amazing program. I'd love to know if you're at the Manassas campus or the Richmond campus. So please type that in the chat. I'd love to know who you're at so I know which teacher to harp on. But I guess we all have our own kind of cards in our pocket for surgery where, if I get called in, because I live in the area, I know which doctor I'm going to say do not and which doctor to say please do, and it's all personal preferences. And you have the same thing for your team. If you come in for surgery, a lot of us who have to come in here, you say, can I please have blankety, blankety, blankety to be a part of my team to take care of me? Right? Because you just know who takes care of you the best. And, in all honesty, I will say the one person that I would be okay being my tech in my room would be in this. If we look at the screen, if my pictures are still up, the gentleman in the bottom left and top left corner, his name's Kenji. He was a Lord Fairfax student, and he came on as a brand new student with me, and I trained him in cardiac surgery. And he's just kind of been, I don't want to talk him down by saying protege, but he's been the person that I feel has far surpassed any training I could give him, and ends up training me in a way. But he'd be the one that I would let operate on me.
That's great. So Jordan said that he's at the, or she, I'm not sure. Jordan is at the Manassas campus.
Tell Miss Tennant I said hi.
Transitioning from a paramedic.
Oh, very cool. It's a big career change for you for sure. ECPI was very awesome to me when I was learning. Miss Tennant is an incredible teacher. She will scare the bejesus out of you when you're doing your fake clinical training in the labs. She's intense, but she makes everything worth it. I promise you. So if you ever get into any trouble, and that they include my email and all of this, I'd be happy to help you with anything you need through your program. And just trust in what Miss Tennant teaches you.
And Darlene, I'm going to read this next question, and then I'm going to head on to the next session to meet our presenters.
Okay.
But the question is, advice to anyone who would want to look into being a surgical tech but have not started yet.
It's a kind of it's a hard question. It's to be a surgical tech, it takes a lot of different personality traits, in my opinion. You just have to be ready for stress. So I would say there's some really good videos online with a gentleman who has a YouTube page called Surgical Tech Tips. I can't remember his name off the top of my mind in particular in the videos, but he does all these videos about a day in the life, where his hospital has allowed him access to video while he's at work and what he does. And when I was starting, watching his videos were a big reason why I actually went for the surgical first assistant path. He talks about it a lot, and he talks about what it's like to open a table, what it's like to sterilely gown. He kind of just takes you through a day. He even brings in surgeons to show what the importance of a surgical tech is. So my suggestion would be to go watch him on YouTube, and that's Surgical Tech Tips. And that's an amazing thing. Or just to contact your local hospital or Mary Washington and see if there's any techs that are willing to chat with you about about programs and about what we do. I know I'd love to talk to anybody that is interested in surgical teching. So yeah, just get involved. That's the biggest thing.
Thank you, John. So we have another question. If you have already had some allied health classes taken, can they add it to the program to fast forward the program for an interested student?
So that depends on the facility and university you're going through. Everyone's going to have different accreditation needs that they have to meet. And sometimes, unfortunately, they won't accept credits taken at some facilities, but that's going to be something you want to talk to your academic advisors about, especially. I came from, being in school for business or just a generic degree I was trying to get before, and none of my classes transferred at ECPI except for my math classes. That was just a personal situation for me, but it's just going to depend on where your credits are coming from and if your facility allows it. So.
Okay. We have a few more minutes. Oh, I'm sorry, Darlene.
No, are there any other questions, Mary? I couldn't tell. Can you see any other questions for John?
There are not any other questions. So I was just going to say we have a couple more minutes if anybody would like to pick John's brain and ask him any more questions.
I actually have a question. It might be something that someone else is thinking about, or to me then, because of what I do here at Mary Washington. But hey, John, oftentimes we do get a number of people who would like to shadow in the OR. Okay. Mm-hmm. Matter of fact, we get so many requests sometimes that it can be overwhelming. From your perspective, what do you think a person actually gets the opportunity to see? So my question is, what do you think people should be allowed to see? Now, keeping in mind that maybe this is the first time they are getting a chance to go into the operating room, as an observer. Mm-hmm. Should they be able to see? What should they expect to see? And what would you suggest that they, maybe there are some things where you would say, absolutely not. We would want people to see this or that.
So we actually get a lot of first timers in the OR. When Germana rotates their nursing students through the operating room, it's in their first semester with no clinical experience, with no background, essentially. You're in your first, just gotten finished with A&P, essentially, anatomy and physiology. So when they come in, that we deal with this all the time. What I will say is laparoscopic procedures are a very easy one for a lot of people because you aren't seeing organs out of a body, which is a big kind of shock for some people. For me, I thought it was the coolest thing ever, and I couldn't get enough of it. But there are some stomachs that don't handle it the same way, or a lot of blood. So having laparoscopic procedures, which is where we use a camera inside the belly. So lapra, which is abdomen, right? So laparoscopic, we're using a camera inside the belly to do some sort of general surgery, either on different portions of the colon, small bowel, the appendix, maybe even gallbladders, which we do a lot of here. Because everything's going to be on these screens. If you kind of look behind me, there's a couple screens hiding up and TV screens all over the place. You get to come into the operating room, see the environment, experience, kind of just what happens around you, and you get to watch it on a screen. Now, myself being the lead in cardiac surgery, I always say cardiac surgery is the best case for a student to see if you can stomach it. If you think that you can see very big and impressive things, our students stand right behind me where I am here. Behind me, you can see is our operating table in the cardiac OR. I'm sitting where our nurse anesthetists are when they're giving the anesthesia, and this is where we operate. And we have our students on a step stool behind me, looking over the drapes down into the open chest, which is the coolest experience to see a beating heart. But again, for everybody that it was the coolest thing ever. But for anybody that's coming in, just understand your limits. Never be afraid to ask to sit down. There is no being, the cool person or being the hard butt saying, "Oh yeah, I can do it. Oh, I'm good." We've had enough people that have passed out. We've had to catch people. They're starting to throw up. We have to walk them out. Never be afraid to say when. There is nothing wrong with saying there's an issue or I need to step back for a second. Never feel ashamed, never feel embarrassed. This is a learning experience, and it's going to take some time to get used to these, big changes. It's not normal to see the inside of somebody's body. It'll never be okay, except for in this very intricate setting. But it's going to take some getting used to. So come in with an open mind, right? And always be ready to say when.
That's good advice, John. That's very good advice. I just can't imagine, but I will tell you, John, through career development, we get a number of the requests, which we funnel to, the team over there in the OR, and we're just getting a number of requests. Just, Mary can tell you, seems like every day we're getting something around an observation for the OR. So I wonder if that means that just more people have interest in it. Maybe that means, I don't know, people are just more curious. I think being here today, John, is really helpful because, again, just based on what we see in the chat, you have a lot of people that are interested in wanting to learn more. So we are happy to help to funnel some of the questions, any additional questions that our participants may have. We can take those questions and definitely send those to you. We have all of the participants' contact information, so we can help with that sort of we can help to be a liaison.
One thing I do want to add into a lot of the interest coming into the operating room, and at least for the people who are here, I do want everyone to understand just the importance of what we do in the operating room. And that's why it's so hard to get viewing time in the operating room. When you're under anesthesia, you're paralyzed, you're asleep, you have no control, right? Your life is in the hands of the professionals in the operating room. Now, when you're at your most vulnerable, the last thing you would want is someone who isn't involved in the care just watching you. Patients are naked when we start to do our surgeries. Letting somebody else see you naked or seeing you get operated on, it's a big trust to allow somebody to come into the operating room to see these things. And I think that the cool factor of the OR, it kind of overpowers the thought of how delicate viewing these things can be, right? It's very special to be able to view something in the OR. And if you get the opportunity to do that, take it seriously, don't goof off. But if you don't get the opportunity to be in the OR, that's why. It is a great chance, it's a great opportunity, cool things to see, but it's also very serious and people's lives are on the line when we're in here. So depending on the allowance of who gets to come in and come out, that's kind of the reasoning why. Not everyone's going to be able to get in. It's not an open door. It's something that takes a lot of different approvals to get into. So just understand that not everybody can see it, which is unfortunate. I wish everybody could, but there are video accesses for people who don't have the opportunity on different channels on YouTube.
So John, how many people would you say are usually in an operating room?
In one room by itself?
Yeah.
So for general surgery, you would have your standard team, which is one tech, right, manning our instruments, one surgical assistant helping the surgeon, and then we have our circulating nurse, which is an RN. It's somebody who is a professional in the operating room. She does all of our charting. She's a big asset to everybody equally in the operating room. So the scrub tech is scrubbed in, the surgical assistant is scrubbed in, and our circulating nurse is the one person on the team who is not scrubbed in, being our big hands-on person to handle all the electronics and do that too. So there's usually about 3 people involved outside of the surgeon. Now in the cardiac OR, it's a different story. Obviously, there's a lot more going on in here. So we have our anesthetist as well. And sorry, I didn't mention that before, as well as our circulating nurse. We have a nurse anesthetist who monitors all of our medications and anesthesia the patient's getting under. But in the cardiac OR, we have our nurse anesthetist, like I mentioned. We have our circulating nurse, our scrub tech, our surgical assistant, our surgeon, but we add an extra person. They're called perfusionists. They are the amazing people that run our heart-lung machines. So when we do heart surgery on most patients, we have to stop the heart. And to do so, we have to put them on cardiopulmonary bypass, which is when essentially a machine is their heart and lungs. It takes the deoxygenated blood away and gives the body oxygenated blood without the heart having to work. And the person who controls all those electronics, pumps, blood flows, they're in the room as well. So between 5 to 7 people would be a typical team.
Okay.
And I just saw a question. I did my clinicals at Mary Washington Hospital entirely. I did not rotate. At the time, it was an opportunity to stay here. I knew I wanted to work here. So I just went head first and ankles deep and said, screw it. I'm going to do all my clinicals here and hope they hire me. So, yeah. But I would say as some advice to doing clinicals, take the opportunity to work at multiple different places to see how it's done. There's a lot of ways to drive a car. Not everyone does it the same, but it's good to have everyone's input, right? So that's a great way to learn and your clinicals. Take everyone's opinions and make your own at the end.
Excellent.
Yes, ECPI did offer clinicals at Mary Washington Hospital. Sorry, I just figured out how to pull the chat up. This is really cool.
I was like, how is he doing this? No,
I just oh, this is awesome. ECPI offered it at Mary Washington, but contracts change. So I'm not sure what the current contract is like. With COVID, things changed a lot for studenthood at every hospital I know of. So things are just a little bit harder, and those contracts have gotten a lot stricter. So check with your director. And Jordan, I believe you said ECPI. So check with Ms. Tennant and see what the availability looks like to be a student with Mary Washington.
Okay, so we got one more question here. So John, I don't know if you see that last question.
Oh, I just saw it pop up.
From Kayla. Oh, okay. Let's see. Had to remove yourself from an operating room due to a disagreement in care.
So that's a really fantastic question, actually. Everybody on the team in surgery has an opinion. And a lot of times those opinions don't need to be shared in some ways because, of course, we don't have the knowledge and backing and residency and training that surgeons do. But I can tell you that there's been a handful of times where I've pointed out things that weren't seen by somebody because a second set of eyes is always better. Am I right? Having an extra set, that's why we're here, right? High reliability. We trust each other. We need to be given the opportunity to speak up for the care of our patients. So I've never had to remove myself from an OR due to the fact that my patient's my priority. Have I disagreed on the care of patients? Yes. Have I voiced my opinion? Yes. But if I am told that decision is wrong, or that's a great opinion, but we're going to go this way, you have to appreciate that on both sides. I gave my opinion. I've done what I can, right? They've taken it into consideration and they've now explained why that's not a good idea. But removing yourself from an OR should never be in your mindset. Your priority is your patient. And if you leave your OR, you're leaving your patient and you're abandoning them. Never have that mindset, right? Now, if you're being forcefully removed from an OR, if you're being told to leave the OR, I've been told to leave an OR before in my training just because of just because, no, yeah, stop watching TV. Grey's Anatomy is too crazy for you. Just because of learning, you're in a very complicated case. And when I was new, I made a couple mistakes and I was told you need to be relieved by somebody with more experience. And that happens. But no, you'll never stomp out of an OR angry, throwing things because you don't agree with the care of a patient. That doesn't happen. Everything needs to be considered high reliability. And Mary Washington takes their high reliability extremely seriously. So everybody has an open opinion. Everyone can voice that. You just need to do it in a considerate way that has respect to everybody else in the room, especially the patient.
So Mary, do you want to go ahead and wrap up? Was that me or you this time, Mary? I forgot. I'm sorry.
We can tag team it.
Okay. All right. Well, let me take the first part. I'm going to thank John because John, as you know, then you have participated in 2 of our programs and under short notice, and we better understand just how busy you are. So we really appreciate the time today. The students and participants may not realize just how lucky they are to be able to get you during this time and to get this information. So again, students, if you have questions or anything like that, keep in contact with us. We can get you connected to John. I did put the survey in the chat. You guys are used to this, but it's pretty much the end of the day. So grab that survey link really quickly. And we are about to go to one last session, but you can't miss this one because we're about to hear from both VCU and from Mary Washington about open positions. So please jump to the next link. What did I forget, Mary? I know I forgot something.
We're hiring surgical techs, by the way.
You heard it from John directly. So everyone, let's jump over to the next session and I'll see everybody there. Thank you, John.
Thank you so much.
Thank you,
John.
everybody.
You've been amazing. Bye, guys. See you in a second.